Hello and welcome. My name is Joe Caramelli and I oversee Grand Rounds for the Department of Psychiatry and Behavioral Sciences. And thank you for joining today's Grand Rounds presentation. A couple of things about Grand Rounds. This year, we've tried to have many of the presentations consistent with a theme called Next Steps in Care. Today, we have the topic of translational research related to early psychosis and next steps related to that. There's a core group of us who work on Grand Rounds each week, which includes Samhar Abraha on coordination and communication, and Mike Walker on technology. We record and archive all the presentations on the department website in the Grand Rounds section, and you can see presentations from the past there. I want to acknowledge funding for the series from the Ripley Fund and from the Garvey Institute for Brain Health Solutions. And a couple of things about the presentation today. Closer to the end of the presentation, I'll put a link for a Grand Rounds evaluation in the chat. It's 5 questions. Please consider completing that, and that information is helpful for me in planning Grand Rounds and communicating with the presenters. And you can write in comments and questions in the chat or the Q&A, and I'll keep track of those and can go through those at the end of today's presentation. And now, for an introduction for today's presenter. Today's Grand Rounds presenter is Dr. Dost Ongor. Dr. Ongor is currently the Chief of Psychotic Disorders Division at McLean Hospital in Massachusetts, and is responsible for all clinical services serving patients with psychotic disorders, which includes the first episode Psychosis subspecialty program there. Now, he's also the William P. and Henry B. Test Professor of Psychiatry at Harvard Medical School. And his research has focused on psychosis and early psychosis using brain imaging approaches to probe brain abnormalities in individuals with psychotic disorders, as well as clinical studies to understand trajectories of illness in early phases of these disorders. He's currently the PI on a P50 Center grant from the National Institute of Mental Health focused on early psychosis research. Now, Dr. Ongor has won awards from McLean Hospital, from Harvard Medical School, from the and the Kempf Award from the American Psychiatric Association for teaching and mentoring. And I want to point that out. I was reviewing Dr. Ongor's CV earlier and saw at least 10 individuals on K Awards for which Dr. Ongor is the primary mentor over the last 8 or 9 years. And I could understand this award for mentoring, given the substantial amount of mentoring and clinical research. Notably, Dr. Ongor is also editor-in-chief of JAMA Psychiatry, one of the top journals in the field, and incoming president of the American Psychopathological Association. Now I'll stop there for now and turn it over to Dr. Ongor.
Thanks very much for the invitation and for the introduction. And good afternoon to all of you. It's great to be with you. Of course, I wish I was there in person in Seattle to visit the department, but I'm thankful for the chance to speak with you all about the work that we're doing in early psychosis. So this is my funding and disclosure slide. I did give a presentation at a for-profit company earlier this year and received honorarium for it. That's the only interaction that I've had with a for-profit entity in the last 3 years. In today's talk, I'm going to try and do a few different things. Really start with a general introduction to the idea of early intervention in psychotic disorders and psychiatry. Talk about a little bit of our own research on the neurobiology of early psychosis, but then really pivot to the clinical phenomena of the earliest stages of emergence of psychosis, including the prodromal period. And then also talk about early psychosis treatment issues. As some of you probably know, there's a lot going on here nationally and internationally about designing treatment programs for people with first episode psychosis. And then related to that, I'm going to talk about our own LEAP Center, which stands for Laboratory for Early Psychosis Research in Massachusetts, and give you a flavor of some of the work that we're doing in this space ourselves and leave you with some conclusions at the end. So starting with early intervention, I like to show this slide as a visual demonstration of why we all should care about psychotic disorders, things like schizophrenia and bipolar disorder and related conditions. This is actually a survival curve from the whole entire country of Denmark based on the registries, the national registries that they have. The orange profile here is looking at the proportion of people who are still alive at any given age, for men on the left, women on the right. And as you see, most people are alive coming into your 70s or so, and then there's kind of an inflection point around age 80, and then by the time you come out to age 100, not as many people alive. And the same thing for women, but right shifted a little bit. And then you see the green profile, which is for people with bipolar disorder, and the yellow profile, which is for people with schizophrenia. And hopefully this image will really impress you with what an impact these disorders make on our societies, that they can be fatal. They rob so many of our citizens of the ability to have a good life, a life that they're happy with, and they can in fact literally be fatal, and the mortality is high, just like the morbidity is. And this image really, for me, it's all you need to know about why we all should care greatly about psychotic disorders, and feel that there's a great unmet need here. We need to be able to do something better for our patients. So another way of saying all of this is that psychotic disorders are a significant public health burden. And many of you who work with these patients know that non-adherence, frequent relapses, ongoing disability, these are the realities. These are the general experiences of clinicians. But actually, it turns out that long-term outcomes following a psychotic disorder diagnosis are not always adverse. Many people regain functionality. There are people out there, a few, who require little or no care. But what we have as clinicians is a clinician's illusion that leads to pessimism and wrong messaging for patients and families. And what I'm referring to here is that if you're sitting in a clinic, whether it's an outpatient clinic or an inpatient unit, and you take care of patients with psychotic disorders, you would think that the only thing that we have is non-adherence, frequent relapse, and ongoing disability, because those are the people who come to care. Those are the people who need our help. Whereas there is a part of psychotic disorders that's community-based, and we may not always know about patients with good outcomes because they're no longer coming to care. And so when you see the next young person being diagnosed with schizophrenia, and you say to them, all you're looking at is decades of bad things happening, you're actually misrepresenting the reality, and that patient and their family are not getting the right message. There is room for optimism. And I'll show you two studies here. The one on the top is from Australia, from Pat McGorry's group, looking at follow-up of 600 plus individuals with psychotic disorders. And over the subsequent years, you see that 57% of people with schizophrenia or schizophrenia disorder reported some paid employment, symptomatic remission, again, roughly 50% of the cohort, and social vocational recovery, which is a lot harder, in almost a third of the cohort. Similar story out of the UK, Paula Dazan's work, again, over a couple of hundred people, and you look at recovered and non-recovered individuals. And in non-affective patients, you have several dozen out of 200 who are classified as recovered based on their criteria. And of course, first episode mania or depression, the numbers are even more favorable in affective disorders. But even in non-affective psychosis, in schizophrenia spectrum disorders, you have a substantial number of people who would be classified as recovered. So good outcomes are actually a part of psychotic disorders, and we don't always pay enough attention to this. So how should we be thinking about psychotic disorders and early intervention? Well, mental disorders are chronic diseases of the young, with their onset and maximum impact in late adolescence and early adult life. Many of you have probably heard the statistics that 75% of psychiatric diagnoses have been made by age 21, and then even about 50% by age 14. So psychiatric disorders have their onset early on in life and their maximum impact in adolescence and early adult life. Early manifestations are fluid, long-term outcomes are variable. And I'll give you the punchline now for early intervention. Both neurobiology and epidemiology research indicate that psychotic disorders, in particular, severe mental illnesses, schizophrenia, bipolar disorder, and related conditions, have a significant developmental component. So, in other words, what happens when you're diagnosed at age 18 or 20 or 22 with a psychotic disorder is not the beginning of the story. It's actually the culmination of a series of events that have been unfolding with your genetics, with in utero environment, with perinatal adverse exposures, and then early childhood and mid-childhood and adolescence exposures, all of which come together to tip the balance of the brain over to a psychotic disorder diagnosis. So if you think this way, you realize that what we should be doing is not waiting until somebody has been diagnosed with a psychotic disorder, but be looking for those risk factors early and intervening. So in other words, we view the onset of a psychotic disorder as a critical window of opportunity for intervening to prevent long-term disability and not as the start of inexorable decline. The focus should be on improving long-term outcomes, not on palliative or symptomatic treatment. Of course, we care about giving our patients some peace and quiet away from hallucinations or delusions. But the outcomes that we should care about just as much, if not more so, are, can we get them back to work? Can we get them back to school? Can we get them to be living independently? Can we have a situation where they're living lives that they're happy with? And we can't wait for miracle breakthroughs in research. Of course, those would be nice, but the unmet need is now, and we have to be doing it now. If you've seen the article in the New York Times or seen the book from Tom Insel, former NIMH director, he makes a similar point. Of course, he's somebody who's advocated heavily for more biological research and miracle breakthroughs in research in his career, but at least he's now coming around to the idea that we can't wait for miracle breakthroughs. We need to do something now to improve the care that our patients are receiving. Speaking of Tom Insel, this slide is from a paper that he wrote over a decade ago that really highlights the developmental trajectory. So on the top panel here, you're seeing age, actually from fertilization all the way out to young adulthood. And he shows the various processes that take place in a normally developing brain. And then at the bottom, in the bottom panel, he shows the childhood and adolescence period and the deviation from normal for various brain processes. So in people with schizophrenia, you see some myelination deficiencies. Myelin, of course, is the insulation material, the fatty substance that insulates the connections between different brain regions. That's why we have the white matter, because the myelin itself appears white. And in people with schizophrenia, you actually see deficient myelination. You also see abnormalities in both excitatory synapses that use glutamate, the chemical glutamate, and the inhibitory synapses that use the chemical GABA. In both of these, there's deviations from normal. And as you can see in all of these curves, these deviations have actually started long before age 18 or 20 or 22, when the diagnosis may be made. Those deviations are already happening at age 5, 10, and 15. So this neurodevelopmental trajectory is already there prior to the onset of illness. This neurodevelopmental perspective argues for both primary and secondary prevention. Primary prevention via reduction of exposure to risk factors. These are things like poor prenatal care, adverse childhood experiences, urbanicity. There's some interesting research coming out here that light pollution, noise pollution, but especially air pollution, actually impact the developing brain in adverse ways. And one of the subsequent outcomes can be neurodevelopmental and neuropsychiatric disorders. And then especially in adolescence, cannabis exposure. These are all risk factors. If they could be reduced, we might actually have a reduction in the incidence of psychotic disorders. That's a big statement, and it's really far from proven. It's speculative, but the primary prevention framework suggests that this is something we should be looking at. And then secondary prevention, which is what I've been talking about, early detection and intervention in people who have the illness. This is another thing we should be focusing on, is catching them as soon as we can and getting them the best care possible so that we can bend the long-term trajectory. This is a very influential figure from a paper that's almost 25 years old now, but many of you have probably seen this in the textbooks, that people with schizophrenia, there's a natural history to this, that the premorbid and prodromal stages, slight abnormalities might start to emerge in clinical manifestation and pathophysiology, but then with the first episode, you have the onset and deterioration of functioning and brain function. And then for a lot of people with schizophrenia, after about a decade, they can settle into a residual phase where there can be some ongoing relapses, but actually the clinical presentation is not as active as it used to be, but you see more of a neurodegenerative picture, if anything, with cognitive deficits and negative symptoms. And of course, the big question is this red mark here, the red line here. Can we bend this curve with early intervention, primary and secondary prevention, so that outcomes for people with schizophrenia are better than they are now? Unproven. There's no easy answer to this, but this is really, of course, the big philosophical background that brings us to the research that we're doing now. So I'd like to next give you kind of a flavor. This is, of course, by no means exhaustive, but I'd like to give you a flavor of the kind of research that's going on in the field, and especially the work that we're doing. In terms of brain research and psychotic disorders, broadly speaking, of course, we know the brain is a dynamic, complex system. There are countless feedback loops and compensatory mechanisms. And then there's ongoing dynamic balance in the brain to maintain important parameters within narrow ranges. And in psychiatric disorders, we don't have simple lesions or degeneration the way you do with a stroke or with Parkinson's or Alzheimer's diseases. Instead, we have subtle changes in the rules that govern the behavior of this dynamic and complex system. And so we really ought to be interested in concepts like controlled plasticity and response to perturbation, because ultimately, of course, the brain's task is to detect patterns in the environment and to prepare a behavioral plan that meets that pattern. So there's a lot of learning that goes on with plasticity, and then there is response to perturbation. When the environment changes, the brain needs to change with it. So concepts like homeostasis, which is staying within a narrow range, which is what the brain likes to do, and allostasis, which is if you cannot maintain that narrow range because the environmental pressures are too great, at least can we now maintain the brain in a narrow range that's not in the homeostatic range, but a new range called the allostatic range. These are the kinds of concepts that a lot of neuroscientists are working with in thinking about psychotic disorders too. In other words, with schizophrenia, we are not going to find a lesion in the brain. We're not going to find the gene that causes schizophrenia. We're not going to find a chemical that causes schizophrenia. Schizophrenia is a property of a complex system. So we have to understand how these complex systems get broken. And if you want to do that, you really have to worry about the synapse, because plasticity and perturbation happen at the synapse. Synapse, of course, is where two neurons communicate with one another. In this cartoon, you have a presynaptic neuron and a postsynaptic neuron. The presynaptic neuron has the neurotransmitter that's these red spheres. In this case, it's glutamate. The postsynaptic neuron has receptors that listen to the activity of that presynaptic neuron. And then you also have glial cells, these blue profiles here, that take up the glutamate in this case and inactivate it so that the glutamate isn't diffusing throughout the brain. So there's a very clear, specific pattern here in how the synapse actually is supposed to function. Well, this is all very energy intensive. And you can see these pink profiles both in the glial cell and in the neuron. These are mitochondria. Mitochondria generate ATP, and ATP is the energy currency in all of our cells in our bodies, not just in the brain, but throughout the body. But the brain in particular is very energy hungry. In fact, gram for gram, the only organ that matches the brain for how much energy it burns is the heart, which is, as you know, quite literally a physical pump that never stops moving as long as we're alive. So the brain burns as much energy as the heart, which is really quite impressive if you think about it. And where is the energy going? Well, a lot of research has shown that the energy is going literally into supporting synaptic activity. So if you're interested in synaptic plasticity and interested in perturbation and response to perturbation, you should be interested in ATP supply, energy supply. And that's exactly where some of my own research has been in the last decade, looking at energy supply in the brain. We can use a technique called phosphorus magnetization transfer spectroscopy. P31 is phosphorus in this case. Phosphorus MRS is the abbreviation we use to look at how much ATP is being generated in the brain over time. And because of the way we set up the experiment, I'm showing you a graphic here, and you see these curves that are dipping down with the passage of time, 2 seconds, 4 seconds, 6 seconds, and so on. And the deeper the curve goes, the more ATP is being generated. And I'm showing you data from a group of people who are healthy controls. And as we look at their brains in an MRI scanner, we're collecting data, no radioactivity, no needles. This is just an MRI scanner the way you would get an MRI scan if you had hurt your elbow or your knee. But in this case, we can actually collect data that tells us how much ATP is being generated compared to a group of people with schizophrenia. And as you can see, people with schizophrenia are generating less ATP. That curve is not dipping down as much. When you do the calculations, this calculates out to about a 22% reduction in the pace of ATP being synthesized in the brain. It's a very statistically significant and also, of course, biologically significant reduction in ATP generation. I'm showing you this paper that was from chronic patients, but we've replicated this in first episode, and our first episode patients have exactly the same abnormality. Well, so I laid the groundwork to say ATP synthesis must be important for synapses, and in schizophrenia, you don't have enough ATP synthesis. But what are the implications of that in our patient population? So in this paper, we looked at brain connectivity and how ATP synthesis makes an impact on that. Those of you who do this kind of work or have seen research presentations about network connectivity in the brain using resting state fMRI are going to see this as a familiar picture. It turns out that the blood flow changes in the brain, which we can measure using fMRI or functional MRI, fluctuate over time, and different brain regions actually have signals that fluctuate over time in an organized way. So brain regions that are very distant from one another can actually be showing the same time signature, which is what you see in these orange and red regions in the brain. This is actually what has been termed the default mode network, the medial prefrontal and this retrosplenial region and the lateral parietal regions, these four nodes of the default mode network. And then other brain regions that have a different time signature are in the blues and greens here. And these are actually the task-related networks. So very generally speaking, the default mode network is internally oriented processing. When you're not giving a talk or listening to a talk or reading a book, you're just sort of daydreaming, you're in your internally oriented processing. These brain regions become active. And then the task-related regions become active when you are engaged with the outside world in a specific way. And the two are actually anti-correlated with one another. So one is active, the other is inactive, and vice versa. And so we collected this data, this functional MRI data, in a group of people with first episode psychosis and also with healthy controls. And we replicate what everybody else sees, that there is this default network and this task-related network. Now, when we do the correlation with ATP synthesis on the x-axis with connection within the task network, within the default network on the y-axis, I'm showing you that on the left, and we can do the same thing for ATP synthesis on the x-axis and the anti-correlation, the reverse correlation between the two networks on the y-axis. I'm showing you that on the right. And you see that in both cases, there's really a strong relationship between ATP synthesis and connectivity for healthy people in green, so that the more ATP you have, the more network connectivity you have within networks, and the more anti-correlation you have between networks. In healthy people, this is true, but this is actually breaking down in people with first episode mania or first episode bipolar disorder and also first episode psychosis. So ATP synthesis is both reduced, it's not there, but even for when it's there, it's not actually making an impact on network connectivity, which is abnormal. So we see this as evidence for an impact from this ATP availability, the energy availability, on the network connectivity of the brain. So if you're interested in metabolism, insulin comes into view. If we think that there's not enough metabolism in the brain, not enough ATP being synthesized, the energy supply isn't there. Well, we know insulin, of course, in the rest of the body is the key regulator of energy supply. And so we wondered, what is insulin sensitivity like in our patient population? We did a study looking at insulin sensitivity using the oral glucose tolerance test. So this is the same test that's done with pregnant women to check for gestational diabetes. And it's a very simple test where you drink a big glucose load in a big glass of sugary water, and then you draw blood samples every 10 minutes, and you look at the curve of the body's response to that glucose load, and you can calculate insulin sensitivity. And we saw something quite amazing. In our first episode, a group of our first episode patients, insulin sensitivity is roughly half of what it should be, even though these are otherwise healthy, young, lean people, no diabetes, not even pre-diabetes. Their BMI is similar to the matched control group. The mean age here is 20 and a half. So these are young and healthy people, but they happen to have a first episode of psychosis. And we also recruited their siblings, by the way, who are also their siblings, so they're young also and lean. And these siblings are not taking any medications. They don't have a psychotic disorder the way the patients do, but they happen to have that genetic risk for the psychotic disorder because they share roughly half their genes with the patients. And you see that insulin sensitivity is actually almost as bad in the siblings as it is in patients. It's really a remarkable trace of an abnormality that suggests that there's something about this energy metabolism that's already abnormal in first episode. And it's also, you see it in people with a genetic risk for the illness who themselves don't have the illness. And in the patient group, when we looked at insulin sensitivity versus a composite cognitive battery called the matrix battery, we see a relationship. So the higher insulin sensitivity, the better cognitive function in our patient group. This suggests to us that the energy metabolism, once again, has an impact on brain function. The other thing we've been studying using this phosphorus MRS approach is NAD. NAD stands for nicotinamide dinucleotide. It's a small chemical. It's a cofactor for many reactions in the body, and it has impact on all these very important things that happen in our cells, like energy metabolism, mitochondrial metabolism, redox balance, this is oxidation reduction, circadian rhythms, inflammation, DNA repair, chromatin and epigenetics, and so on. It turns out that we can actually measure NAD levels in the brain using phosphorus MRS, and that's exactly what we've been doing. And the most important ratio is the NAD plus NADH ratio, because this actually tells us about oxidative and reductive stress. And in people with chronic schizophrenia, we see an abnormality in this. In people with first episode schizophrenia, the abnormality is even bigger. In fact, the normal NAD-NADH ratio in the brain is supposed to be about 5. And in this matched group of healthy young people, that's where it is. In first episode schizophrenia, it's around 2.5. There's literally a 50% abnormality in the NAD-NADH ratio. It indicates actually a metabolic slowing and the reductive stress. In this case, it's not oxidative stress. We can talk more about that if you're interested at the end. And then in people with first episode bipolar and first episode psychotic mania, in this case, these are all bipolar 1s with psychotic features with their mania. They're somewhere in between the healthy young people and the first episode schizophrenia patients. So we see this big abnormality in the NAD metabolism. And it's linked with the rest of the metabolic abnormalities that we see. We did the same thing in relatives, and we see that relatives actually come in somewhere between the matched healthy controls and the first episode patients. So even though, again, they're young and healthy, and by the way, many of these relatives, you know, when we recruit them, they're siblings. They have gone to good schools. They are working in good jobs. They have, for all appearances, above average trajectories. They just happen to have a first episode patient who's their sibling. And yet, when you study their brains, you see this, you see the signal of an abnormality that seems to be there based on the genetic risk. One of the reasons we're excited about the NAD work is because, first of all, we can measure it in the brain. So we have an outcome measure, and you can actually give people NAD supplementation. One of the chemicals is nicotinamide riboside, or NR. And we're interested in this one because it's actually orally bioavailable, and it generates NAD, which crosses the blood-brain barrier. So we're actually doing a study of NR supplementation, hoping to normalize this NAD abnormality that we see using brain imaging. So far, we've done this with 4 healthy individuals, taking a gram a day for 2 weeks, and we can see an elevation in the NAD-NADH metabolism. Here I'm showing you just data from a single patient, a single participant rather. The blue tracing is the MRS data from before they start the study, and the orange tracing is after 2 weeks of NAD supplementation. And you can see that we're actually starting to normalize the brain levels of these chemicals. So we think that this might ultimately become a therapeutic intervention for our patient population. But of course, a lot more remains to be done. So that's really, like I said, just to give you a taste of the neuroscience research that's going on in the field and the work that I'm doing in that domain. Now I'm going to move on to a lot more of the clinical presentations of psychosis, starting with the very early stages, the at-risk states. So this is a very complex slide, and I'm not going to walk you through it. The point of the slide really is that there's no one pathway to developing schizophrenia. By the time you get the first episode, which is this vertical stippled line right here on the right-hand side of the slide, a lot has happened, and different patients get there through different pathways. Some people have what are called APS, or attenuated positive symptoms. These are things like having hallucinations and delusions, but maintaining your reality testing on it. So a patient might say something like, you know, I feel like my landlord might have put microphones and cameras in my room because I feel like I'm being watched. But it doesn't make any sense, right? Why would they do that? I'm just going about my business and not hurting anybody. And then at some point, when they start to lose that insight, they flip over to frank psychosis. So one way to get there is APS. Another way is brief, limited, intermittent psychotic symptoms, or BLIPS. These are full-blown psychotic symptoms, but they last for hours or a few days at most, and the person can actually go there but come back from it. And then they can tell you about it. You know, I really was convinced that this was going on, but now I realize that it wasn't. So that's another way of developing psychosis. And then there is a more kind of pernicious long-term development of cognitive dissonance. People feeling like something is wrong, but they can't quite put their finger on it. But the world isn't what it should be. People aren't who they say they are, this kind of thing, without a clear psychotic explanation for it. And this cognitive dissonance pathway can take longer to evolve and get to psychosis. So anyway, again, there are different ways of being at risk for psychosis. There is no one category. There's a lot of research going into this, and people are actually developing clinics, at-risk clinics, where you can recruit individuals with these problems and intervene in the hopes that you improve detection of at-risk individuals in the community. You serve the clinical need that they have, because a lot of at-risk individuals are anxious and depressed. They may be abusing substances. They may not be psychotic, but they actually have plenty of psychopathology. And of course, the holy grail is preventing the onset of a psychotic disorder. We don't know if that's possible, but wouldn't that be great if we could actually detect people at risk and be able to do an intervention that at least reduces the odds of onset of a psychotic disorder. We'd like to shorten duration of untreated psychosis, even if you can't catch them before they've become psychotic. If you catch them soon after they've become psychotic, that would be great. And then reducing symptom burden and disability generally. So there's a movement in the field for early intervention at the earliest stages of these at-risk individuals that are really a diverse and sort of pluripotent state. But the more we can do for them, the better. You're going to be hearing a lot more about this, I'll predict now, because of this major new initiative that NIH has funded recently called AMP-SCITS, which stands for Accelerating Medicines Partnership for Schizophrenia. This is the AMP-SCITS website. There are several websites that have already been formed at this point, but this is a global, international, multi-site collaboration funded by the NIMH, and the NIMH is actually investing about $100 million in this international collaboration over the next several years. So stay tuned. If you're interested, you can follow this for sure. A lot more is going to be happening in this earliest stages, the at-risk syndrome, clinical high-risk world of who are these patients, how can we detect them and identify them, and what can we do for them that makes a big impact. Of course, the M in AMP is medicines, but this is not only about medicines. Medicines is a big part of it, but other therapies are also going to be studied. A couple of other things I want to say about this. One is about cannabis, the other is about psychostimulants, because we're talking about primary prevention. And there's a lot going on in the cannabis field. I'm not going to go into it in detail. Suffice it to say that the epidemiology is clear that middle teenagers around age 15 who are smoking daily cannabis are at about a 3 to 6-fold higher risk of developing a psychotic disorder subsequently. We can debate causation, all day long. We don't know if, of course, cannabis is causative, but it's a risk factor and it's a marker of risk. And we should be doing something about this. I highlight this because the debate about cannabis in society has been going in one direction, whereas our understanding of cannabis and psychotic disorders is going on in the opposite direction. Most people in society nowadays have this impression that cannabis is totally safe. There is no downside. In fact, if you stop somebody on the street and you ask them about tobacco, they can tell you that cigarettes cause lung cancer. If you ask them about alcohol, they'll tell you pregnant women shouldn't be drinking alcohol. But if you ask them about cannabis, they might think that it's totally safe, whereas it's very clear that it's a marker of risk for psychotic disorders in teenagers specifically. So I really agree with Eden Evans and her colleagues who are at Mass General right down the road from us here in Boston, who say the time is right for the United States to follow Canada's lead and invest in public health education and messaging regarding cannabis as legal but not safe for younger users, particularly of high-potency products. So this debate is not about whether cannabis should be legal or illegal. The debate is about society being aware that there's a very specific risk for middle teenagers who are smoking weed daily. They're at high risk of a major life-altering psychotic disorder diagnosis, and we need to be aware of that. And the second is about stimulants. This is work from my colleague Lauren Moran, who did this work here at McLean, published in the New England Journal a couple of years ago. She used large commercial databases, insurance databases, to identify young adults who received over 200,000, a stimulant for attention hyperactivity disorder. The percentage of patients who had an episode of psychosis within 60 days after starting the medication was higher among amphetamine users than among methylphenidate users by about a twofold. And the series of sensitivity analyses really did not identify any factors that could explain this finding other than whether you're taking amphetamine salts or Adderall, or you're taking methylphenidate or Ritalin. And of course, amphetamine salts have a higher potency for releasing dopamine in the brain than methylphenidate does. And it's possible that that's the explanation for this higher risk of psychosis. And again, when you're thinking about primary prevention in people who are at risk, prescribing amphetamines to people who are at high risk of psychosis is probably putting them at higher risk. And this is another thing that we should all be aware of. Okay, so that's the at-risk world. What about once you've been diagnosed? How should we be thinking about early psychosis and first episode psychosis and all the treatment issues? Well, I'll give you the punchline here right off the bat as well. The standard of care now in the United States is that people with first episode psychosis should be receiving coordinated specialty care, or CSC. CSC is team-based, it's multidisciplinary, so it's not sufficient to put up a shingle that says, if you have psychosis, if you've just been diagnosed with a psychotic disorder, come see me. You actually have to have a plan to have a team that's delivering a comprehensive care model that's intensive, similar actually in many ways to ACT, assertive community treatment. It's person-centered, it's focused on engagement, bringing people into the clinic, recovery-oriented, prioritizing return to work and school, and not a deficit-based model where we focus on things that our patients are not able to do. We focus on recovery and their priorities in a person-centered way. There's psychoeducation for young people who are just coming into contact with the mental health care system for the first time, and also their families. Phase-specific treatments so that the treatments are commensurate with what the young person is experiencing. A good example of this is not putting people on high-dose antipsychotics, on day one, but dosing the medication, potentially trying to treat the first episode with a lower dose, which oftentimes is possible. And time limited. In many cases, many models are 2 years, although this is now being debated. CSC in the United States really follows the RAISE model. RAISE stands for Recovery After an Initial Schizophrenia Episode. This was NIMH funded, a large multi-site study that established that the coordinated specialty care intervention is superior to treatment as usual. But of course, we're not resting on our laurels. There's a lot of talk about a RAISE plus approach. This is from Dr. Keshavan, Macheri Keshavan, who's down the road from us here in Boston. He suggested that there are certain elements that should be added to RAISE, added to the existing CSC models, things like cognitive remediation, things like peer provider involvement, which is not part of CSC at the moment, but of course peer specialists can be very impactful in helping people with psychotic disorders, and better coordination with primary care and emergency rooms and so on. There's a few items like that could be part of a RAISE plus approach. But at this point, we have meta-analytic evidence that early intervention services are superior to treatment as usual in a variety of outcomes: hospitalizations and treatment discontinuation, remission and recovery, symptom severity, hospitalizations and duration of hospitalization, and also global functioning and quality of life. Every one of these metrics, early intervention services are superior. So there's no doubt where somebody should go if they have a first episode of psychosis now. In fact, it's even better than that. Clinical trial evidence is one thing, but a recent paper, a really fascinating paper out of Denmark, suggests that real-world data are just as good, if not better, than clinical trial data. Because Denmark is a small country with a good national registry, they were able to look at outcomes of the OPUS system. The Danish OPUS system is their network of first episode clinics. There is an iconic OPUS clinical trial that was published a couple of decades ago now. I think 2004 was their primary outcome paper. And the red and the green curves for hospitalizations, mortality, and suicide tell you about the Opus arm and the control arm from that clinical trial from a couple of decades ago. But now they were able to actually look at patients who received their treatment in their Opus clinics around the country in real life, not in a clinical trial. And they could follow those patients in their registries without having to collect data and have dropouts and loss to follow-up and all the rest of it. They can actually see mortality, suicide, and hospitalizations in the control arm and the Opus arm. And as you can see, the orange curve is actually favorable, or at least as good as the clinical trial data. So in real life, patients who went to Opus since 2004 and got care there after being diagnosed with schizophrenia for the first time actually have very good outcomes, if anything better than what they were getting 20 years ago. Now, of course, there's a lot we can discuss here, like a cohort effect. Maybe things just have gotten better in society in general for these patients. That may be true, but at least we're not seeing a worsening in real life outcomes. In the United States, we don't have that kind of data yet, but we're going there with EpiNet. EpiNet stands for Early Psychosis Intervention Network. It's another NIMH-funded consortium, including 8 regional hubs, 101 clinics across 17 states, and there's an EpiNet National Data Coordinating Center. This has been really assembled in the last 3 years by NIMH and is now starting to function as a national system. There are multiple hubs in California, Texas, Indiana, Minnesota, and so on. We at McLean Hospital in our LEAP center are the Massachusetts hub for EpiNet, so we're participating in this. EpiNet, the intention behind EpiNet is to form a learning healthcare partnership. So the idea of a learning healthcare system is this sort of circular system where you're constantly collecting data from your clinical experience as a matter of course, not as a research study, but really just as your clinical experience. And then you're analyzing those data in a continuous loop of quality improvement, and then discovering what works and what doesn't work and how care models should be improved, and then collecting data again on your new care model and so on. So the cycle continues. This is not a new idea. The National Academies of Science, Engineering, and Medicine had a report over a decade ago now about learning healthcare systems and how this is where medicine should be going. But this is one of the first implementations of a learning healthcare system in psychiatry is happening in early psychosis with EpiNet. So EpiNet is going to collect what's sometimes called big data. The goal is to collect data from about 10,000 people with first episode psychosis around the country in all these different clinics about their clinical presentation, comorbidities, what treatments did they receive, socioeconomic background, family involvement, various other factors, and then follow them over time and be constantly collecting and reporting data to EpiNet Data Coordinating Center so that over time we can actually analyze those data looking for clues for personalized treatment, randomized quality improvement projects, rapid piloting or fielding of new approaches, and even evaluating rare events like suicide with statistical power. And this is where the LEAP Center comes in. LEAP Center was NIMH funded, launched in 2019. We work closely with MapNet, which is the Massachusetts Psychosis Network, which was funded by the Massachusetts Department of Mental Health, launched in 2018. Together, we've implemented standardized data collection. We devised a statewide strategic plan for early psychosis care. And really at this point, we have a system, a network of clinics within Massachusetts that are all working together and reporting data to EpiNet, but also forming as our own learning healthcare network within Massachusetts. And I'm really pleased to say that LEAP Center is the one of the leaders of that. We've been reporting on our experience, a strategic roadmap for Massachusetts. This is a paper that appeared last year in Schizophrenia Research about our experience in Massachusetts, and also the lessons learned from a pilot implementation of harmonized data collection. Also reporting on the common assessment battery data collection across 14 clinics in Massachusetts. The number was lower when we wrote this paper, but it's growing all the time. We've also started analyzing some of this data. One of the things we looked at was COVID impacts. So here I'm showing you employment and education as proportion of our patients who are actively involved in each. The solid line is 2019, pre-pandemic. The stippled line is 2020, and of course, the stay-at-home order and closure of schools in 2020 came in March. And of course, we saw a decline in the proportion of our patients who were working or going to school soon after the pandemic started. Interestingly, in the fall, there was a return to school for first episode patients in Massachusetts, but there was not a return to work. So it appears that there is a particular vulnerability for our working first episode patients that we should be worried about and getting them back to work. We are now analyzing the 2021 data, and we're seeing a continuation of a similar pattern. So when you have this kind of standardized and routine data collection in a network of clinics around the state of Massachusetts, we can actually, do this kind of analysis and start to make a contribution to the first episode psychosis literature about the challenges that our patients face. Other topics that we're studying within the LEAP Center: outcomes in individuals who are referred to CSC but don't make it in the clinic door, because we have no illusion that we're capturing all of our patients in our CSC clinics. In fact, we're only capturing about 10%, maybe a little more. There's a large cohort of people out there in the state who are never receiving CSC care for a variety of reasons, and we want to study them as much as we're studying the ones that are in our CSC clinics. Impact of cannabis on first episode psychosis trajectories for reasons that I already talked about. First episode affective psychosis, first episode mania with psychosis. This is a special interest of mine because we see a lot of these patients at McLean, and there's such little literature on this. Their treatments, trajectories, and outcomes. So we are now collecting standard data on them as well, and we'll be able to both compare them with first episode non-affective psychosis, but also contrast them and look at their specialized needs. COVID impacts, I've already been talking about, but also COVID impacts on providers and the abrupt transition to telehealth, which went well at first, but of course some cracks have appeared in that facade. So we need to be mindful about the impact of COVID on care provision. Role of peer providers that I already mentioned. Access to care, expanding capacity within the state, because again, we're only caring for probably 10 or 15% of all people with a first episode of psychosis in our CSC clinics. Serving underserved communities and diversity in clinical teams and elsewhere. This is another strategic priority for the state of Massachusetts. And because of the diversity of the location of our clinics around the state, we actually have a very diverse population of patients we're following. So we will be able to provide the State Department of Mental Health with data about the best places to make an impact for underserved communities. And also reducing staff burnout and turnover. I don't know what it's like in Seattle and Washington State, but everybody I talk to around the country tells me that there is a great deal of staff burnout and people are quitting their jobs, and it's gotten harder than ever to hire clinicians. So we're in the middle of this very challenging period where care provision has also become difficult. And so we're very interested in that topic within the LEAP Center, and we're starting to do some research with it as well. Okay, so to leave you with a couple of thoughts, and then I'm happy to have a discussion about any questions you have. I hope that what I tried to tell you, it was clear that we really need to think of early phases of psychotic disorders as a critical period for intervention. This is not the same thing as a chronic clinic, a chronic patient clinic. We have to think of early intervention as a special calling. Neurobiology does not provide a single target for intervention, but it does force us to consider the complexity of evolving brain function as psychosis unfolds. So again, we're not going to have a miracle cure. We're not going to have a single lesion or a single gene that we can target. We have to be thinking of the complex system that is the brain and how to target it in the earliest phases of schizophrenia or psychotic disorders. And we know that existing treatment strategies make a positive impact on outcomes. So we also have an implementation challenge. It's not just about discovery, but also about implementation. And so we are actually, the transition is underway from research to implementation. Local and national collaboration is going to be essential for progress in delivering team-based care. This is difficult to do in the US. It's easier to do in smaller countries with better, more harmonized and unified healthcare systems. But I think the national collaborations, especially EpiNet, is starting to make some progress in this. Of course, we still have much to learn about what is the right intervention, what is the right duration, what populations will benefit from the most, and so on. So I think in the coming period, you're going to see more clinical trials and also more observational data sets that are being analyzed for deciphering clues to all of these questions. And again, I come back to that, what I call the $64,000 question: can we bend the curve in the real world and make a real impact for our patients and their families that actually reduces the unmet need that's out there, because we really aren't there yet. So I'll just acknowledge several of my colleagues who particularly have worked with me on the imaging studies side, and also, of course, our patients and their families. And I'll leave you with an aerial view of McLean Hospital. It's not always like this, 4 or 5 months out of the year we have snow on the ground, but now we have a nice spring and summer is coming soon. And we have a wonderful campus right outside of Boston, and hope you come out and visit us sometime. Thanks for your attention.
Well, thank you, Dr. Unger. What a remarkable presentation through 4 or 5 different domains of research, clinical practice, establishing a clinical network for research. It's very interesting. I'm not sure which area to start with, but a lot of questions have come in. And I guess maybe we just start and move backwards. But a lot of us who work here have experience with trying to collect data from clinical practices, depression measures in primary care, for example. What was it like to get this set up with practices in the state? Were people enthusiastic about it? How did it go? How did you agree on measures?
Probably you can predict some of the challenges. Buy-in and uptake from clinics can be challenged. And there was an aspect of this where both patients actually and clinicians who have to do these assessments, right, as part of our standardized data collection, say to us, well, I already know what I know, and I'm presenting it to you, and you're telling me this is going to be a value add somehow. You'll tell me the patterns, but it doesn't actually feel that exciting to me. So that was absolutely there. One critical factor that you might predict is finances. So what I didn't go into is that the federal government actually has been earmarking dollars from SAMHSA, the SAMHSA block grants, going to states. 10% of those actually have to be now spent on early psychosis care. And states, a lot of the DMHs or departments of mental health and related departments are actually making data collection a condition of funding. So if the state is saying we're going to pay you to run this clinic, but then you're obligated to collect data for us, then the conversation changes. So how the finances flow, how the incentives are set up, makes a big difference. But on top of that, of course, we've tried several things to make it worth their while for the clinicians and the patients. So we have actually an interactive dashboard that clinicians and clinic administrators can use that actually shows them both how their clinic is faring, but also compares them with statewide benchmarks. We have raffles and small financial incentives to make people feel appreciated if they are completing the assessment batteries. And also the design of the assessment battery, the FNet steering committee that I sit on, spent several days worth of work, 20 hours plus on fine-tuning the assessment battery. And the biggest consideration was low burden. So we picked instruments and we picked domains that we felt were both critical and as low burden as possible. So it's really, the assessment burden is 30 to 45 minutes once every 6 months. So that becomes, a little more acceptable than if we were being more ambitious.
Well, thank you for your comments on that. And a question came in. You mentioned about, I think in your conclusions, that neurobiology isn't yet a target for intervention, but is it a target for diagnostics? Do you see that as coming soon? And how might that relate to classification like in DSM?
It's a great question, big question. I think in the short term, well, first of all, taking a step back, what we mean by diagnostics, I think that's a realistic question, and we're definitely closer to that than to, leading to a meaningful breakthrough cure or treatment. But in terms of diagnostics, we don't need a tool to distinguish sick from not sick, right? We need a tool that maybe tells us something about prognosis or treatment response, and maybe also about diagnosis. We know how to do the first now. There's definitely very good classification algorithms, especially in the last decade with machine learning and artificial intelligence, and also multimodal neurobiological assessment with multiple kinds of MRI, EEG, cognition, and so on. We really can, in fact, now classify people pretty reliably as having a psychotic disorder versus being totally healthy. But unfortunately, that's not really what we want. We want those other things. And we're not there, but I think it is a realistic discussion that's starting to happen. Part of the problem, of course, is that this is going to have to be iterative. meaning we don't have gold standard diagnostic categories to measure our biology against. So telling schizophrenia from schizoaffective is not a particularly useful exercise because those are fluid categories and experts disagree and so on. So what we really need is to use the neurobiology to inform diagnosis and then be able to feed that back onto the neurobiology to see if the discrimination is getting better and better. That's a complicated process. It's actually, I would say it's underway, but we're not there.
That's very helpful. Yeah, I appreciate the distinction between diagnosis and maybe using something for prognosis instead, or predicting risk in those maybe at elevated risk. Another question, perhaps one of the final questions, so we could wrap up here a minute or two before the end, about this, what clinicians often see with each recurrent episode of psychosis, maybe functional recovery becomes more difficult or challenging. Is that, will you comment on, do you see this? Are there neurobiological markers of this? Do you see this in epi studies, for example?
Yes, short answer is yes. I think there again, causation is difficult to really nail down. In other words, is it the fact that you've had these episodes that every time you have an episode, something is breaking, so to speak, that the disease is advancing? Or is it the accumulation of adversity, the loss of income, the breakdown in family relationships and other things? I guess you can, you can argue that that's a kind of causation too. In other words, we don't know that it's necessarily neurobiological, but in epidemiology literature, very clear that people with multiple episodes have poorer functional outcomes than people with single episodes. It's also clear that there is advancing brain biology. In fact, there's a lot of debate in the field about whether schizophrenia has a neurodegenerative component because of this. It's very clear that it's not neurodegenerative in the same sense that we think of for Alzheimer's disease and others, but maybe there is a component that there's a neurodevelopmental component until you get it. But once you get it, it might trigger something in the brain that causes tissue loss, in particular, the gray matter loss, that may be progressive. And that has been linked to having more episodes, more hospitalizations, more relapses. So there's probably something there as well.
Well, I think we should wrap up here. I want to thank Dr. Unger today for this really notable and remarkable presentation in multiple domains of research and clinical practice and systematic data collection within large systems of practice. Thank you for this presentation, and thank you for the participants for joining us today, and we'll end there.
Take care. Bye-bye.